Good afternoon, everyone. For those who are presenting today, you should be able to share your screen, but I have the presentations up in case you run into any technical difficulties. Good afternoon, everyone. We'll be getting started shortly. If you could please put your name and organization in the chat for attendance purposes. And this meeting is being recorded for note-taking purposes.
Good afternoon, everyone.
Good afternoon.
Emily, I'll wait for your cue on when we can get started and when we have critical mass. It looks like we have a huge number of people, 48 already on at 2:02. So very prompt and timely number of people.
I think we can get started.
All right. So I'll formally call the meeting to order. It's 2:02. And with that, I'll turn it over to Emily.
Thank you. So our first agenda item today is just the acceptance of the April minutes. Can I get a motion to approve the April minutes? Are there any changes needed?
I'll make the motion. Is there a second?
Second.
Thank you. Motion is
Thank
made
you.
and seconded. Any need for corrections, edits, additions to the minutes as presented to the team? If not, so ordered. We'll accept those minutes as presented.
Thank you. So our first agenda item today, I'm just going to be doing some brief administrative updates. Following that, we will have project updates on our UCC and Crisis Continuum marketing and communications work from both Daydream Communications and United Way. And then we will merge into two presentations, one on substance use service array and then another on suicide prevention. So all you should have seen an email from me this past week, but I just wanted to put it here as well that the TCB bill, House Bill 5447, did pass both the House and the Senate last week. The link to the bill is included in the slides if you do like to look at any more additional information. I did want to take time as we do have a new member of the TCB team. Ryan, if you're on, feel free to come off mute and introduce yourself.
Hi everyone, my name is Ryan Connick. I am moving into the TCB Senior Project Coordinator position. I have actually been with the Tag Youth Justice Institute for about 2 years now, but I will be moving on to Emily's team. So I'm very excited.
Thank you.
Welcome, Ryan.
And Emily, I didn't want to go through too quickly, but I do think it merits a pause to just reflect on the bill that passed. And I know several people on the call here today worked incredibly hard to help formulate those recommendations and the supporting justification and then work them through a legislative process. So I wonder if it would be worth a minute to talk through some of the key elements of that bill. And for that, I certainly want to recognize TJ Nuccio in particular for bringing us some of the recommendations related to eating disorders and creating a work group in the commission to look at how eating disorders intersects with behavioral health issues, and then some of the ideas that he worked with the education chairs on related to screenings at the school-based health center. So just to tee up some of those elements, I was hoping we could tip to TJ. I think you're on. You want to just talk through some of the work and remind people of the rationale for putting that forward and some of the good progress we made this year in the TCB bill?
Yeah, absolutely, Claudio. Thank you for the opportunity to reflect on the bill, House Bill 5447. I'm going to start with just, talking about a little bit of the rationale for why some of the eating disorders and disordered eating work was included in the bill. This was based upon research that was conducted over the last year and a half here at the Commission on Women, Children, Seniors, Equity, and Opportunity on eating disorders. And we are seeing rising trends in eating disorders among our youth in our state, in which we, as a result of that increasingly harmful trend, the commission, along with many of our partners here on the call, we created several policy recommendations that went to various committees in the Connecticut General Assembly. We had some in the Public Health Committee. I did see Representative McCarthy Vahey on the call. Thank you to you and your great work on that. And then we had a variety of recommendations in the Education Committee. We consolidated everything in the TCB bill. I'm just going to be brief and talk about the respective eating disorders sections. If anyone wanted to comment on anything else, feel free. The eating disorders, it's two working groups. There's one of them that is generally geared towards looking at the treatment of eating disorders. And then there is another one that creates a holistic food education working group, which is really going to look at some of the disordered eating behaviors that may be a reason for the increases in disordered eating that we're seeing in our state. And then very importantly, Section 4 of the bill actually looks at it requires our school-based health centers to use an evidence-based screening tool for their early detection of disordered eating behaviors. That mandate is set to kick in July 1, 2027. So it's pleasure working with everyone on the committee. I want to be very grateful to Claudio, Senator Marr, and Representative Exum for their due diligence working this into the late nights of the hours last week. So thank you, Claudio. I'm happy to answer any questions as well.
Thank you, TJ. And just to round out, another key section of that bill was related to some of the complex care needs. So last year, there was an interest in trying to figure out where there was need to have better throughput across our system, a continuum of care where children were getting stuck in EDs and hospital placements, and how can we look at feasibility assessments for gaps in the continuum of services. So there's Section 3 of the bill, which sets up a process by which DSS, in collaboration with state agencies, sister state agencies, will look at the feasibility and design of creating inpatient facility for psychiatric treatment disorder for young adults between the ages of 14 and 21. Really thankful for some of the work that led up to that, a lot of the constructive conversations across multiple state agencies and OPM to try to figure out where there's a real gap and how we can thoughtfully try to address that for better throughput across our continuum of services. So I think it's a holistic package. Very pleased that the legislature supported it with unanimous votes in both the House and the Senate, and thank our legislative champions for getting it done. So thank you, Emily. Just wanted to make sure everyone knew the good work and product coming to fruition.
Thank you. Are there any questions or comments before I move on? We'll go back to administrative updates. So some brief work group updates. As you all may know, the System Infrastructure Work Group has been meeting in a subgroup in regards to system of care. So at our last meeting, we went through a draft policy paper created by one of the co-chairs. And from that discussion, a group of individuals within that subgroup will be creating a document or presentation of sorts to present at our June 16th meeting, which will be touching upon Connecticut's current structure. For school-based, we have been very busy with our 3 legislative charges. So within this past month, we had 2 different subgroup breakouts, one focused on the special education legislative piece, which is currently chaired by Tom Kosker from the Disability Rights CT, and he went over phase 1 of the project updates with that subgroup. We also kicked off our school billing subgroup, and we have contracted with Solix or Civic Solutions Group on this effort. So more updates will come at the June 1st school-based meeting, and we will actually be having larger, more thorough project updates at the June TCB meeting on both of these efforts. And then for prevention and services, you'll see the agenda is pretty much the same for the month of May. We will be having Jill Farrell from the Innovations Institute come and present the initial findings from the Connecticut Children's Behavioral Health Provider Survey Report. And those meetings will take place on May 28th and May 27th. So I'm going to pass the floor to Howard now, who wanted to provide some staff updates.
So I'm just really excited and pleased to introduce the 2 new staff members that joined the Office of the Behavioral Health Advocate. Angelica Gill, who's on the call today, is our new Behavioral Health Program Associate, and Colleen Mastriani, our Assistant Behavioral Health Advocate. I'm going to ask each of them to introduce themselves really quickly. I don't want to take up too much time, but I'd like you to become familiar with them and the work that they're going to be doing. So Angelica, you want to start?
Sure. Hi, everyone. So I'm Angelica. I'm a licensed clinical social worker by trade. I come from working my beginning of my career working in eating disorder treatment, IOP, and PHP levels of care, working primarily with adults. And then I made a transition to private practice where I was a clinician and a supervisor. So supervising clinicians as well as helping out with billing and seeing clients 13 plus and helping with practice operations.
Great, thanks. Colleen?
Yes. Hi, good morning or good afternoon, rather, everyone. I'm Colleen Mastriani. I am an LPC by trade. I am the new Assistant Behavioral Health Advocate in the Office of the Behavioral Health Advocate. Over the last 10 years, I've had experience in both the private nonprofit and state operated systems. I've overseen several community-based programs as well as outpatient services. I've worked as the program manager of Child First, as well as the child outpatient at Intercommunity and some of their other community-based programs. And then I took a shift in my career when I moved to state service in addiction services. So I'm coming from Connecticut Valley Hospital for the last 2.5 years, where I was the program manager of the addiction services division of Connecticut Valley Hospital.
Great. So we are now up and running. We're actively, positioned now to begin to accept more referrals for consumers and families who are seeking help in accessing care, as well as private licensed professionals who may be having trouble with the insurance companies that may result in them choosing to pull out of networks. Those are our two major mandates, and we're happy to be available now and to be up and running. So thank you.
Thank you. So before I jump into this section of the agenda, which is the UCC and crisis continuum. Oh, sorry, Claudio.
Hey, Emily, I just, for purposes, because I know we are on CTN today and there's a lot of people that may be hearing this, and certainly the Behavioral Health Advocate is a new resource that some people could take advantage of. And especially May being Mental Health Awareness Month, it's perfect time to let them know about these resources that exist. I was wondering, Howard, if people are hearing and may have a need to reach out to your office, help them understand what role and unique cases would come to you as opposed to the more general healthcare advocate, helping to triage what are the unique use cases that your team is better positioned to take forward and how they would contact you.
Yeah, we're set up primarily to be an independent voice specifically for the behavioral health community. So we're there to provide individualized support to consumers and families who are having trouble navigating what sometimes is a very complex fragmented system of care to get them. The goal is to get people to the right level of care at the right time. And for those providers and potentially consumers who are having trouble with the insurance companies, either getting paid, having problems with credentialing, or having other administrative burdens that they are finding as obstacles to delivering the care that they need. So we're working closely with the Health Advocates Office. We work closely with the Department of Insurance and try to provide both expert content expertise to those two entities, as well as providing sort of a concierge service to our mental health providers and consumers. Okay. And our homepage is up on the web, so you can search and find us and get contact information there. Okay.
Thank you, Howard.
Thanks.
Thank you. So before moving on to our next section of the agenda, which is the UCC and crisis continuum marketing and communication piece, I just wanted to briefly level set the background of that work. So as some of you may be familiar, last year in our legislation that passed, we are legislated to do a crisis continuum review report, which is looking at the utilization of crisis services, marketing and outreach efforts. And in the beginning of this work last fall, with the help of Howard, who is leading this subgroup, we really focused in on the marketing and communications piece for both the UCCs and the larger crisis continuum. So we've been working with the behavioral health advocate Howard, Dr. Bozak and DCF, CHDI, United Way, and the UCCs on these efforts. And we do have bi-monthly to monthly work group meetings where we meet as a whole to provide project plan updates. So our next one will be coming up the first week of June. So with that, I will give the floor to Katie Gallo and Sarah Nelson from Daydream Communications.
Thank you. Let me just share my screen. Can everybody see that?
Yes.
So I'm Katie Gallo. I lead Daydream Communications, and Sarah Nelson is our Senior Account Director. We're a marketing agency based in Norwalk, and behavioral health is our specialty. So we are working with a number of state agencies and groups across the state in a variety of capacities. Doing marketing. We are the first certified recovery friendly workplace in the marketing sector in Connecticut. Sarah brings national level experience from SAMHSA. She led the 988 marketing campaign there. And as far as my involvement, I sit on the board for NAMI Southwest Connecticut, as well as the Connecticut Adult Behavioral Health Planning Council. We're also working with Howard and Demas as well. So we're very embedded in this work and are knowledgeable of the subject matter. So the situation we were brought into is to promote the urgent crisis centers, because the problem is they're underutilized and there is little awareness of these in the community. So the goal is to increase that awareness and utilization as an alternative to the ER. And to do that, we are developing a research-based public awareness campaign. So what we've done so far, our research took place in February and March of this year, and we really wanted to assess the awareness and the perceptions, as well as the motivators and barriers to using the UCCs. And we spoke to parents and caregivers, as well as referrers. So for the parents and caregivers, we did those discussion groups in English and Spanish, and we also did a survey. There were 28 qualified respondents for the parents. And then for referrers, we did a survey and got 93 respondents. And we also did a stakeholder interview with a pediatric ER physician. And what we found, not surprisingly, is the awareness is low, but the interest is high. So 63% of the parents had never heard of the UCCs, and in most in the discussion groups were also unfamiliar. Law enforcement refers, 59% of those had never heard of the UCCs. The medical and behavioral health providers were more aware, but they weren't sure what criteria to use to refer to the UCCs. And overall, it's the low awareness is the barrier, not resistance to going. So when people learned more about what they are, they do respond positively.
Okay, so I'll jump in here. So this just puts a visual to what Katie was just going over in terms of where kind of awareness lies. We like to look at it in terms of sort of the spectrum. Ideally, we get everybody sort of to the acting and trusting phase, but that takes time. The parents are pretty much in the unaware and aware phase. Or in the aware phase, it's just like a little bit in that. As Katie said, law enforcement, the majority are unaware. We see a little bit more awareness up in with the medical, behavioral health and the school staff. And so this really informs us well in terms of the types of like the sort of the angle we take and the types of messaging we use when we understand where people are on this spectrum. So a little bit more into what we looked at with our research. And again, this is very high level, but something that we always like to know as communicators is what motivates, what are motivators and barriers? Like what would be motivators for parents? What would be barriers for them in terms of considering using a UCC? And so their top motivator was to know that the staff is specialized. They're very qualified in youth mental health. And then another one that's not on here that was just after that is that they're compassionate. They really want to know that the UCCs have very compassionate people that work there. Key barriers for them is, not knowing what to expect, uncertainty about insurance, and then distance. Are they going to be close enough to a UCC? And then the Spanish-speaking parents have distinct needs that are going to be very important for us to address in messaging. And this includes knowing if there's bilingual staff. They have concerns about, possible separation from their children. They want to know, can you go if you're undocumented? So a lot of sort of safety types of questions that we would want to address. And then for the referrers, what they want to know about, and again, this tells us right away what we know we need to give them with the different materials, is they want very clear criteria about when is a UCC the right call. They want to know what happens then after they make a referral. And then it was also really helpful for us to learn that they are primarily learning about UCCs through their own channels, like through their workplace trainings, through different requirements, different protocols, et cetera. And so that kind of helps us to think about how we would reach them.
Go
Okay. Go ahead, Katie.
So as far as planning the campaign, our focus is going to be on the parents and caregivers. The awareness building through that would come through paid digital advertising, and we're looking to do that between July and December of this year. So our geographic targeting would be within a 1-hour drive of the 3 UCCs. And we would have distinct content for Hispanic parents. So it's not going to just be translated content, but make sure that it's culturally relevant for the Hispanic community. And as far as supporting referrers, we want to provide resources that the partners can use and distribute it with that clear criteria that they're looking for. And, as far as them referring more, that is a broader institutional change that needs to take place. So it's not going to be all of just related to these materials, but embedding awareness of these UCCs into their professional trainings and continuing education and other workplace protocols will help increase those referrals as well. So what we're saying to them is, in a mental health crisis, your child deserves specialized, compassionate care, and you can find this at the urgent crisis centers. So this is not the exact wording of every ad, but this is the core message that we want to get across. And as Sarah mentioned before, we really want to highlight that you're going to get specialized staff who know how to help the children and teens. They're going to be compassionate. You don't need an appointment. And we want to make sure that people know what to expect before they arrive. One of the other things that the research showed is parents were very concerned. They wanted to be kept informed and involved in their child's care plans. So we want to make sure that that message gets across, and as well as the safe space and bilingual staff for the Hispanic parents. So where we are now, we are developing 2 to 3 creative directions that we'll be sharing soon, as well as our paid media plan and channel strategy. So how we're going to reach our target audience, and then our launch would be in July of 26. So that is our overview. Emily, do you want questions now or after?
Question now, we're fine.
Okay.
I see Jean has her hand up.
Thank you so much. Jeannie Milstein, Director of Human Services in New London, and we are very fortunate in New London to have an urgent crisis center, and your presentation was excellent. I'm wondering, I saw that you've interviewed law enforcement. Have you also talked to the EMTs, because they're, they transport a lot of our patients, and they're starting to use the UCC much more now. I mean, obviously we're a small community, but I'm just wondering if you talked with them as well.
So the law enforcement, that was with a survey, and we just had an overwhelming response from law enforcement. Sarah, I think we had a couple.
Yeah, I think a few EMTs were in there.
But for whatever reason, we had a very overwhelming response from law enforcement in general. Edith?
Yeah, I just had a quick question about, again, great presentation. This is obviously on the marketing front, right? To get families through the door, and but the hope also is that everything that you just mentioned will be their experience as well, right? Staff that specialize, who are obviously very welcoming and, the experience of care. And I'm
Right.
just curious how this information is being shared with those sites, because we certainly wouldn't want, and I haven't even been to a UCC site yet, just full disclosure, but it's almost like false advertising if that's not the experience that families have. And so I'm just curious how that intersects and how the information is being shared with the sites.
No, we want to make sure the experience is authentic. So we do want to involve, photos and information of the real centers and stuff in our outreach. So it's not going to be a bait and switch type of thing. Sarah, do you have anything else to add?
Yeah, I mean, and we're also talking with the UCCs now. Emily's kind of helping us to coordinate with them in terms of making sure that, what is very important to the Hispanic and Spanish speaking audiences. We want to make sure, is it indeed, as safe a space? Is it, do they have 100% bilingual staff, or do they use interpreter services? We need to get the specifics on all of that, but we are coordinating through Emily in terms of communicating with the UCCs to get that kind of information.
Gabrielle?
Thank you. Good afternoon, everybody. Just wondering too around, we have a lot of marketing efforts and we hear from families all the time when we go out and we do community conversations. This is, not a new concept for us in Connecticut of doing those community conversations and where families are hearing information, coming together and figuring out what is the best avenue to market information, right? So we do have existing platforms here in Connecticut already, and I'm wondering if we are going to be maximizing what we already have versus duplicating efforts, right? So that's we fall into that trap a lot, right? And we really need to start maximizing all of the resources that we already have here in Connecticut.
So there was a campaign last year for the UCCs that we can build on. So it's not totally starting from scratch, but it would be a different creative direction from last year.
Well, just even expanding on that though, right? Just like there's other platforms where families just go because they receive so much information in many of these different meetings, such as TCB and some other communities, local meetings. You think about barbershops, you think about supermarkets, right? You think about all of these things where churches and different, wherever they may be, that we have to meet families where they are. So it's not just, the UCC platform, but also the other existing behavioral health platforms that we market in all of our other meetings, along with those non-traditional places as well.
Yeah, so as far as like the actual outreach, we're working on that plan right now for what that would look like, but there would be materials and stuff that could go into those other places that you're talking about that have marketing at other events and venues that would require materials. We could provide those.
And the other websites as well, is my point too. I'll give the prime example, connectingtocarect.org, right? Big platform. We market UCCs there. We share that. It's in legislation. It's all over the place. Where we try to push that website, but there's also other ones as well.
So the information could be on there. It's not where the campaign is driving to. Erica?
Yeah. Emily, it might be good just for level setting for everybody, since we do have quite a bit of people here. It might be good to just provide information about who is part of this group, who's been, because we have to Gabrielle's point, we have connected with a lot. This subgroup has been meeting sometimes even every bi-weekly, right there. And there's a lot of key people in those rooms who would know, for example, Gabrielle, the different platforms that you are talking about. And so it is our hope that through their participation in this subgroup, that they are bringing those ideas, those, hey, raising my hand, our platform here, or CT Connect, or all these other, right, all the different committees and so forth. So that's, that it's a compiling of where all those platforms exist. And maybe it's more of as Katie and the group is building the marketing plan, right? And then we're going to be executing the marketing plan with the purchase of a lot of these materials and so forth, ensuring that, or the infographics and all that, making sure that all of that is sent to the right parties in those platforms. And so, yes, I see Dr. Bozak also mentioned something. So I don't know, Emily, if you want to just give big picture of who is in that room. And I know you'll hear now from United Way soon, which is a nice tee of Dr. Bozak to the next part of this conversation. But I want to say that this, this project consists of two significant buckets to help to increase the education and information sharing. And all the partners are welcome to the table, because that's how we get the message out there, right? And so, Emily, would you like to say who's involved in this overall project? Because we've mentioned UCCs are at the table, not only the providers, but their marketing people too.
Yeah. So I also want to preface, before we actually kicked off this work, we were meeting with that group of people before Daydream, and we had a contract with United Way as well to start brainstorming how this would look. So it includes the 3 base community UCCs, their marketing team, anyone from their team who they think would be helpful in this initiative. It includes DCF, so Dr. Bozak and Frank Gregory have been attending those meetings, United Way, CHDI, and really anyone from those groups are invited to invite additional people that they think would be helpful and informative at these meetings. And the reason for our kind of pulse check-ins is to make sure that everyone is on the same page as we get to a next step in the project. So for example, our last meeting was in April, and we went over the kind of strategic plan for this work with the group to ensure that everyone is aligned and on the same page. And to Dr. Bozak's comment on the chat, I know that United Way specifically has been looking at, platforms that we can promote these materials. And we are checking in with both United Way and Daydream throughout this process to make sure we're on the same page with these 2 separate initiatives going forward. So if there's no more comments or questions, just for the sake of time, I will pass it to United Way.
Good afternoon, everyone. It's really an honor to be part of this meeting and to be on this call. And we're so excited to be working on this project. I'm here today with my colleagues, Jeanette Baker and Amy Casavina Hall, and I'm going to share my screen now. If you can answer me, because I can't see you while I'm sharing my screen, just give an indication whether or not you can see what I'm sharing.
It's not yet sharing, Karen.
I'm not yet sharing. Okay, thank you. Let me fix that. Thank you, Stephanie. How are we doing now?
It's loading now. We can see it, but it's in presentation mode.
Is that bad that it's in presentation mode?
Yeah. I have it up if you prefer I share.
Sure, that would be great. Thank you. Sorry about that. You know what? I'll share another. I can share another slide. I've got it. Sorry, everybody. I've got it for you. Better?
No, yeah, there you go, Karen. There.
Okay, thank you. Sorry about that, everybody. All right. So, and I apologize for the trickiness. So as Emily has outlined, and Eric as well, we're at the second piece of this overall project, and United Way of Connecticut is knee deep and in the process of working on the crisis marketing and messaging the overall crisis continuum. Our goal is to develop a statewide marketing communication strategy for that continuum, to increase awareness, understanding, and the services in the continuum, and to ensure residents know when and how to access the full range of those state-funded services when they're experiencing a mental health need. Step one, Jeanette's going to talk about step one, which really speaks to the question that Gabrielle was asking. So go ahead, Jeanette.
So as we started this project, we wanted to review and understand what youth-related crisis resources were already existing in Connecticut, because through United Way of Connecticut's work with the 3 state agencies on suicide prevention and youth mobile crisis, we knew there were a lot of sites out there. So we began to list some sites, because once this project goes forward with Daydream and United Way of Connecticut, we would want to make sure that these sites, the owners of these sites, know about these new messaging and these new perhaps images, and so that we could reach out to have them update these sites, because as someone from our state is going to, someone might go to Clifford Beers from New Haven, but in New Britain, they might go to Wheeler. So we want to make sure that everyone's getting the same message. So it was our goal in the beginning to say, okay, let's make sure that we know what's out there, so that when it's ready to go forward, these sites can be informed and their websites can be updated. And so as part of this slide highlights the range of campaigns that United Way of Connecticut has executed on behalf of DEMAS, DPH, DCF, as part of an overall crisis system marketing, either for suicide prevention, mental health, or youth mobile crisis. And so over the years, the United Way of Connecticut has implemented a wide mix of outreach tactics, because as someone previously stated, we also wanted to reach traditional and non-traditional. We wanted to be where people were going. And so we really have researched, on the right, you'll see a grocery cart campaign. This was at the ShopRite in the East Hartford, Glastonbury region. We've done them in the Big Y's, but really looking at, if I'm a college freshman, how can I be notified about suicide prevention resources? So could we do an email campaign, or could we do ads in their bookstores where they're buying books? And for high school students, most high schools have sports programs. So we saw, let's put ads on the posters that are saying when the games are. So really trying to think about where people are. Someone also mentioned barbershops. We have done the hairdressing to do a mailing to, because here's where women and men congregate. They feel safe here. This is their community. And so this is a place where we would share materials. So this is really, so going forward, similar to Daydream Communications, we would look at where can we get this message out to? Karen?
Thank you, Jeanette. I hope that helped answer some of your questions. Step 2 of the project. So there is a spreadsheet that we've been sharing internally with this work group, asking folks to update any other platforms or sites that they know of that we can be sure to connect with when we're ready to produce, to execute on these materials. Step 2 is, like we mentioned before, is to really create this youth crisis continuum marketing toolkit for Connecticut to use agency-wide and platform-wide. So there is consistency across the state in how we message about our youth crisis continuum. And we're doing that based on SAMHSA's crisis response framework: someone to talk to, someone to respond, and somewhere to go. So that is the basis of our creative work. Our goal is to create, like I mentioned, that consistency in messaging and marketing, and our toolkit will include but not be limited to, and we'll be providing these to everyone statewide: social media posts, email blast, flyers, web messaging to those platforms, as you mentioned, Gabrielle. So where we're at right now is we have designed several designs and key messages, several options that are youthful in appearance, but are targeted to the youth, but also appeal to parents, caregivers, and referrers. We're making sure that our designs are scaled for different uses. For example, if you have a stress ball or a lip balm, that imaging and that messaging needs to be very different than what's going to appear on large billboards or TV ads or big posters in barbershops. We just this week, we are rolling out those options to a number of kind of mini focus group test options. We're doing that this week with our internal 211 staff across the work that we do, because each staff brings a different perspective. Many of our staff have lived experience as well. So we're rolling it out with our internal staff for feedback. And then at the end of May, we will be taking that information and feedback, massaging and revising and presenting those options to the Community Voices work group that Emily has established. And then we'll bring back our final designs and messages to our overall project work group that Emily mentioned for final feedback and input. So we are also analyzing promotional and marketing methods. Again, these are include but are not limited to promotional products and ads on, again, where we can find both the kids and their parents on TikTok, YouTube, Snapchat, gaming and dating sites. Please don't be alarmed, but yes, there are dating sites for kids ages 12 and up that we're looking into. Discord is very popular with kids. We're also looking in malls, nail salons. I don't know if you've seen the youth these days, but nails and lashes are a big thing. And so we'll be super creative in exploring getting that messaging to those places, coffee shops, anywhere we can find these youth. And we'll be doing a media buys appropriate to those locations as well. Any questions? Andrea, I see your hand up.
Thank you so much for the presentation. One of my questions is, and I think this is great, and there is obviously a need to be able to get the word out there for our crisis continuum for children's behavioral health. I also think, though, that there's this brings to mind for me a huge opportunity to present some complementary marketing to parents and community members before a crisis takes place. So what are the easy opportunities that parents, community members have to be able to reach out when they just have a feeling that something's not okay, but they don't know who to call, or they're intimidated to call XYZ. So, and we do have those sort of, we have those doors that are available in Connecticut. So I guess I'm mostly just offering my, if there's an interest in expanding this to the entire, expanding the continuum to not just the crisis, but also to pre-crisis, happy to be a part of any work group.
Thank you very much. Any other questions? We look forward to sharing the end products and the messages with you all, and to distributing those so that they are consistently messaged across all platforms in the state. Back to you, Emily.
Thank you very much. So I will now go, if there are no other questions or comments, to the next section of our presentations, and I will hand the floor over to Chris Robles at DCF and his team.
Good afternoon. I am Chris Robles. As I'm trying to share my screen, I realized I have to do a little bit of sound, so give me 1 second.
Karen, I think you need to stop sharing. Can you stop sharing your screen? I mean, I think you can, since you're a host, you can stop sharing Karen's screen too. I'm trying to figure this out here.
Can you see?
Sorry, I was on. There you are.
You can see my slides?
No.
Yes.
Emily,
I
you
can.
can, right?
I can see it.
All right, cool. All right, so good afternoon, everybody. I'm Chris Robles. I am the Clinical Behavioral Health Manager here at the department in our Behavioral Health and Wellness Division, overseeing all of our adolescent substance use services, our IPV services, and our recovery services. I have my partner here, Carrie Lloyd, who can introduce herself.
Good afternoon, everyone. Carrie Lloyd. I'm a behavioral health program manager working within the same unit under Chris.
All right. So we're going to go ahead and jump on in for time purposes. We're going to start with some data. So according to our CHDI data in February of 2023 report that they did for Connecticut, youth who begin using substances before the age of 14 are at the greatest risk of developing a substance use disorder. And only 2.8% of our adolescents who need substance use treatment receive it. Substance use during adolescence is high. Nearly 62% of our youth use alcohol and 41% of used an illicit substance by the 12th grade. High school youth identifying as lesbian, gay, bisexual experience higher substance use rates than heterosexual peers at 16% higher binge drinking and 87% of high prescription opioid misuse. Though rates of SUD are similar across racial and ethnic groups, white youth receive SUD treatment at higher rates than Black and Hispanic youth at 55% and 26% higher, respectively. Compounding this access issues, Black male youth may experience a fourfold increase in risk of adult incarceration if they develop an SUD by the age of 16. What we're looking at here is our SAMHSA National Survey on Drug Use and Health, which is conducted annually and helps monitor trends, inform policy, and support and prevention and treatment efforts. This map compares states to one another, with darker color states having a greater degree of concern. Although self-reported rates of alcohol use fall into the mid-color range, rates of cannabis and illicit drug use are at the darkest color, indicating higher rates of use when compared to other states. The bottom right map speaks to youth who needed substance use treatment in the last year, but did not receive that treatment. In Connecticut, again, we are the darker color, and it represents that about 71% of our youth needing treatment did not receive. While there may be a number of contributing factors, we know that there is underutilization of contracted and community-based substance use services. This high percentage is likely larger in under-identification and under-connection issues. We know that kids are out there, but more work needs to be done to identify them and to get them connected to recovery supports. So I'm going to turn to Carrie, is going to talk about some of the work around ASAM and the 1115 demonstration and talk about our peer support services.
Thanks, Chris. So just to kind of level set in terms of what the ASAM criteria is. So ASAM stands for the American Society of Addiction Medicine, and it is a set of criteria that is evidence-based and helps with assessing for level of care placement and treating for substance use concerns. And so Connecticut, under the SUD 1115 demonstration waiver, has adopted the ASAM criteria as its guiding set of principles for the substance use levels of care. We can go to the next slide. So per ASAM definitions, you'll see on the slide here kind of the range in substance use levels of care, with kind of the lower levels of care up near the top of the screen and the higher levels of care, the more intense clinical services being at the bottom range. So when it comes to adolescent services, specifically in Connecticut, we look at early intervention services in some of the work that we're doing connected to adolescent SBIRT, which is screening, brief intervention, and referral to treatment. We have outpatient, intensive outpatient, and partial hospitalization programs throughout the state that provide substance use care for adolescents. But presently, Connecticut lacks Medicaid-enrolled residential levels of care providing substance use services for adolescents. So kind of that lower end of that higher end of the continuum with the 3.1, 3.5, 3.7, 4.0, those residential and inpatient levels of care are areas of growth that we see a need for here in Connecticut. Next slide. So this just kind of gives another visual of the continuum of levels of care and where some of our other services may fall. So the top section and kind of that lighter teal talks about office-based services that might be available kind of across the continuum from lower level of care on the left to higher level of care on the right. And then in that darker blue boxes are home-based services, many of which are contracted and funded by the department. So I won't spend too much time here. We'll move on. Thank you. All right. So in terms of some of the work that the state is doing related to adolescent screening and brief intervention or referral treatment, as I just mentioned, this effort is being done to meet one of the demonstration's milestones around increasing rates of identification, initiation, and engagement in treatment for opioid use disorders and other substance use disorders. So DCF has contracted with CHDI on an initiative that we're calling SUD Focus. And that really supports training and implementation of adolescent SBIRT in outpatient psychiatric clinics for children, or OPCCs. So we had 11 participating OPCCs, 4 of which had newly joined this fiscal year. So the efforts have grown since we launched a few years ago. And some of the highlights from our work thus far, we had over 900 youth who were screened for the first time using ASBIRT in the OPCCs in fiscal year 25. So some significant work was being done to ask questions about substance use and screen individuals for risk concerns. Additionally, under this project, service coordination and substance use training are part of the work that we're doing to help support individuals in getting connected to resources that support their recovery. And also helping to build the competence and confidence of the practitioners within OPCCs to not only ask questions about substance use, but then to help provide the necessary supports and treatment once those risk levels are identified. Some of our new kind of areas of focus include making sure that when risk levels are determined for young people, that the intervention that they're receiving, that brief intervention part of the SBIRT work, matches the risk level being identified. So, for those kind of lower level risks, that they're providing positive reinforcement and kind of reinforcing some of those choices that the young person has made, and for some of those higher risk individuals, making sure that they get connected to services if they're agreeable to that. And we just wanted to highlight as well that there are other ASBIRT efforts happening across the state, and a lot of great partnerships that are happening to explore how we synthesize these efforts and streamline and make sure we're all kind of working together in the same way. Some of those include our contracted provider STRI, so they provide screening as part of their service array. SBIRTs are happening in some of the STAR homes. CHDI has another initiative that they're working on called SBIRT Pass, and then JBCSSD, the judicial branch, is also working on some SBIRT efforts. So lots of great work happening in this area across the state. Next slide. We're not going to spend too much time on here, but just wanted to give you kind of a brief overview. This information is available on our website as well, of the Medicaid enrolled and certified providers for what's called an ACM 2.1 level of care, which is the IOP level of care. So under Medicaid, these providers require certification in order to be able to receive Medicaid reimbursement for those services. And that certification really ensures that they are providing high quality care that is consistent with the ASAM criteria. And then this slide shows our certified ASAM 2.5 or partial hospitalization programs as well. When you go to our website and you see that information, those little blue hyperlinks will actually bring you to the websites for each of those programs as well. So you can find more information there. Medication for addiction treatment is kind of another area that we want to make sure that programs are not excluding individuals from care based off of their use of medication for addiction treatment, and that for those who are interested in receiving MAT, that they're helping to facilitate access for that individual either in-house if that's something they're able to offer, or through other partnerships and other resources, and then kind of ensuring that there's that cross collaboration between systems. We know that for adolescents specifically, buprenorphine is the only FDA-approved medication for youth, but we do kind of capture the full range of medication for addiction treatment services kind of in this slide here. So some new work that's happening here in Connecticut that we're really excited about is our Young People Peer Support Program. So this is a new program that just recently launched, and funding for this is supported under the reinvestment funds of the 1115 waiver. So before I kind of jump into the details about the program, just want to level set with some definitions. For shared and inclusive language, we use some terms interchangeably. When we're thinking about the service recipients for YPPS, we're talking about young people, youth, teens, adolescents. That's being used to describe individuals ages 14 to 17, which is the target age range for this program. I will just add a little caveat that we are expanding that age range to be more inclusive of 12 and 13-year-olds, although our target population is primarily the 14 to 17. And then for the individuals who are serving the young people, we refer to those individuals as peer support specialists, peer bridgers, recovery coaches, and those are going to be individuals with lived and living experience and expertise whose own journey and experience within these systems helps as a connection point to support these young people, help them connect to support services, and help model that recovery is possible. So we might use those terms interchangeably both in the presentation we're giving today, but you might also hear these terms used interchangeably in some of the marketing materials that the programs are using for this service. So beginning on October 1st of last year, we began working in partnership with Choice Recovery Coaching to develop a curriculum that was intended to train the peer support specialists in how to serve young people. So peer support work is not new to the state of Connecticut, but it's been largely in the adult spaces. And we really wanted to support the upcoming workforce for this project to be able to understand areas specific to young people that would make their work with these individuals unique and ensuring that they could understand their developmental and kind of social needs related to that. So we really wanted a curriculum that would hone in on what young people need in terms of this peer work. So Choice Recovery Coaching has developed that for us. They reviewed existing Connecticut peer curriculums as well as best practices for effective engagement of youth with substance use concerns and integrated this applicable content for the target population that we're serving. Also important to note that they, through this process, met with a number of stakeholders, including the convening of a young person advisory board for feedback on things like role definitions, curriculum elements, and the outcome tools that we'll be using as well. And they provided a wealth of feedback into those different areas that, in my opinion, resulted in just such a wonderful product at the end. They also conducted a validation survey to support and revise the knowledge, skills, and abilities for the peer support specialist role specific for this population. Next slide. This kind of gives you an overview of the intensive training that the peer support specialists undergo as part of this work. So you'll see kind of a range of topics that are covered that largely aligns with some of the work being done in other peer spaces. But throughout the curriculum, that young person focus is central to the work that they'll be navigating. Next slide. And then beginning in January of this year, we began working in partnership with Connecticut Community for Addiction Recovery, or CCAR, and Advocacy Unlimited, or AU, to prepare for statewide service provision to young people. So each organization is in the process of hiring 6 young people peer support specialists. And again, they may call those things different titles, as I mentioned in the earlier slide, and 1 peer support program manager. As you can see on the map here, CCAR is serving DCF regions 1, 2, and 5, which is the western part of the state, and AU is serving DCF regions 3, 4, and 6, or the eastern part of the state. Our goal is to serve 140 youth annually. Chris, could you go back just for 1 second? And training is underway. So the peers completed the first 30 hours of the curriculum back in March, and phase 2 of training is actually happening this week. And so they will conclude their training and have already begun serving young people throughout the state. Choice Recovery Coaching will also be providing ongoing consultation to both agencies for model fidelity and community of practice conversations. Next slide. So what is this program? What does it do? So peer support is a voluntary non-clinical service that encompasses a range of activities and interactions to support a young person's self-directed goals of recovery and well-being. So they are taking the young person's lead in terms of what their goals and objectives are, what recovery might mean for them, what wellness may mean for them, even if not focused specifically on their use, and allows them to be the director of where that support lies. Peers are going to offer support around recovery from substance use concerns and any co-occurring conditions that that young person might have, whether those are mental health or medical in nature. They're going to offer encouragement, practical help, guidance, and understanding. They, based off of their lived experience, are a model that recovery is achievable. They share tools and strategies that promote self-empowerment. They enhance, support, or serve as an alternative to clinical treatment. So it can happen alongside, therapeutic services, or it can be in an entity in and of itself. So involvement in past treatment or current treatment is not an area of eligibility for this program for the young person, but they can complement that work that may already be happening. And then they build from strengths and consider the whole person. Peers are non-clinical, so they do not assess or diagnose. They do not push any particular recovery pathway, and they are not providing treatment or case management. Just want to take one last moment on this slide to again emphasize that the program is voluntary in nature. So that young person, again, is consenting to participate in the program and will direct the support that they receive. Next slide. Our target population, again, is individuals ages 14 to 17. We can accept 12 and 13-year-olds into the program as well. They may have co-occurring mental health and physical health conditions, as I just mentioned. And these youth or young people are those who have substance use concerns. And so that's a really broad definition. They do not require a formal substance use disorder diagnosis, nor do they require any sort of formal treatment history. They can have that and still be a participant in this program, but it's not a requirement of the program in order for eligibility to occur. So it really allows for that wide spectrum of individuals to receive the support of this program. And though this program is funded by the Department of Children and Families, involvement with us is not required for access to this program. So it is a free service that is available to all of Connecticut's youths. Young people may self-refer. Their families may also support a referral with the assumption that they've had a conversation with their young person, their child, or the person that they're caring for about their interest in the program. And then referrals shall be accepted from any source, including local hospitals, community behavioral health organizations, DCF offices, youth diversion teams, the judicial branch. And we've been doing a number of presentations kind of across the state to various stakeholders to help get that information out. Once a program receives a referral, they are expected to attempt to make contact by phone within 48 hours and then offer a face-to-face in-person session with that young person within 7 days. We know that there may be communication challenges that delay that time frame, but that's what the teams are striving for. And we're excited to share that both agencies are actively accepting referrals. So if you have a young person in mind that you think might benefit from this support, having a conversation with that young person about their interest in the program, and if they're in agreement, helping to facilitate that referral or encouraging them to call as well. Once the program is involved, the peer is going to be meeting with the youth face-to-face in the community at their homes in the community or at their homes at least weekly. They are expected to have a flexible schedule so that, kind of weekend and evening hours might be able to be accommodated if that's what the young person needs. And then the length of service is going to be individualized. So when that young person feels that they have made the correct amount of desired progress in their goals on their recovery and wellness support plan, that's when those conversations around discharge from the program will occur. But there's no kind of set limit to that at this point in time. All right. With that, I think I'm turning it back over to Chris.
Yep. So we're going to shift from peer supports to treatment. So we're our next section. We're on this slide. We're talking about you have our caregiver services, but for today we're really focusing on our adolescent services, which is on the left-hand side. Well, my left-hand side might be your right-hand side, the way you're seeing it. So this slide basically talks, as you see here, all of our state services that are available statewide, right? So I'm gonna jump into the individual adolescent services next, but you'll see on the MST section there, those items are yellow. Those items are yellow because those are our contingency management. And so I'm going to talk about contingency management when we get to MST, which I think is one of our first services that I'm going to talk about. But I think it's important to have a visual to be able to, for folks to know where are all the services and are they available to statewide, and that's what this does. So MST is our multisystemic therapy standard model. So it's an evidence-based in-home treatment for youth with complex substance use issues, social and educational problems. The treatment focuses on supporting parent caregivers in addressing the youth's behavioral health issues and helping them be successful in managing their child's behaviors. Parent caregivers are active participants in every stage of the treatment process. Most sessions are done within the family and in the home, but it can be done in the community. MST also offers individual therapy with the youth to assist with the family in their therapy process. They provide drug testing at the evaluation and randomly throughout the treatment if it's necessary. There's crisis availability 24 hours a day. Our population is between 12 and 17 years old, and the parent caregiver is required to be a part of that. And as part of their assessment, they'll do a DSM diagnosis related to what the behavioral concerns that are coming up. And the service is around 3 to 5 months, and there's coverage again statewide. You'll see here in red on the bottom are the two agencies that are currently providing contingency management. We get funding through the OSAC to be able to provide contingency management at this point in time. MST is duly funded by both JBCSSD and DCF. Come this July, both agencies are going to be funding contingency management statewide. So each of the services there that you see at the bottom will now be able to offer training for all of the MST agencies, and every youth in our state will be able to have access to contingency management. Some just data, real quick data in regards to MST. You'll see that our out-of-home, 97% for this is 2025, have maintained in the home. 88% of youth have sustained being in school or having a job. 91% of no new arrests. 71% reductions in substance use, and then 83% of youth involved were having some level of peer pro-social and/or activities involved in their life. And then obviously you see that a service such as this helps save the state money, because when we decrease the pipeline of school to prison pipeline, we're reducing recidivism, preventing placements, out-of-home placements. And this type of service is also generalized to their siblings that are also in the home as well. We have our MST Emerging Adult service. This service services individuals that have serious mental health illnesses or substance use or may have criminal justice involvement. They're eligible young adults that have trauma history as well, and they'll also have a history or involvement with child welfare. It is 17 to 21 years old with kids that are aging out or transitioning out of foster care. They have serious behavioral health conditions. The average stay is around 8 to 12 months of clinical treatment with the option of 2 months of life coaching afterwards. And so again, stable housing is they help with stable housing, getting kids situated. You don't need stable housing, nor do you need a caregiver to have access to this service. So you could be an independent, an adult, an 18-year-old, and get a referral. But we ask that as you're going through treatment, that they have those level of connections and supports in their lives to help them throughout their treatment. And so that is our MST emerging adults. And you'll see we only have one provider. Unfortunately, we have only one region. I know CSSD has emerging adult as well through the village. NAFI CT is our DCF contract. They do take region 4 and region 6, and we do exceptions if they do have capacity to be able to meet other areas. NAFI's been really great with taking some exceptions. And CSSD's done great with us teaming when we have referrals that we can't meet, and they have openings. We have our substance use screening, treatment, recovery, youth, which Carrie had talked about, our STRI service. This is an evidence-based model. It uses the community reinforcement approach, assertive and continuing care model. Carrie already talked about that we have our SBIRT, the screening, brief intervention, referral to treatment embedded into this service. Again, trying to get early identification. This is embedded in the outpatient clinics and the 3 providers that have outpatient clinics. The service doesn't need to happen in the outpatient clinic. It can be done in the community. It can be done in school. And the service is for 12 to 24-year-olds. We actually partner with the Department of Mental Health and Addiction Services in their YAS service that they help contribute funding to the STRI program as well. Due to the age of 21 and above, we wanted to ensure that the YAS youth have access to the service if necessary. Our multidimensional family therapy model, we have this is for our ages 9 up to 21 years old. So this is 9 to 21. This can have access to combines our multidimensional family therapy as well as our opioid use disorder modules. So youth that have concerns with opioid use and need medication-assisted treatment or could benefit from recovery monitoring support, recovery coaching. And this is the model you're going to want to access. This is an intensive in-home model. They have availability to be able to provide crisis management 24 hours a day, on call. They can stay involved up to 12 months. With the recovery management support will also stay involved after the 12 months, 6 months after. Again, it's a very intensive model, very much family-based, working with the whole system of the whole entire family while providing peer support as well. We have our youth recovery support. Youth recovery is the purpose of youth recovery is to build a statewide network of youth recovery support services. This service includes peer support meetings for youth in our state, peer support meetings for caregivers and their supporters. It is free substance use, free pro-social activities. We have alternative peer groups that are offered to youth and to their families. We utilize the smart recovery, an alternative model it's an alternative to traditional 12-step meetings. And it's a facilitated support group. And if you, this is just the standard, but if you go to the Youth Recovery website and you click on the meetings and events, you'll get a list it's a calendar of all the different meetings that are held throughout the state. Also under the recovery support for substance use for families, for youth and young adults, there's an icon, there's some testimonials in regards to the services that are being offered in our state of parents talking about their involvement and the youth talking about their involvement of the services that they've received, both on the recovery side and on the treatment side. This is our AIM. So we have our assisted intervention matching tool. And so for those who aren't aware, so our system matching tool sits on our Connecting the Care website. And really the aim of the tool, the aim of the tool is to assist families and caregivers and providers to be able to get connected to the service that best match their needs. So you'll see here on the right-hand side how it works, right? Basically, you go through the process, you share some information. There's a mapping pathway which if you want a full training of this, you'll be able to get access to that. But I want to take an opportunity. I'm hoping. So this is the website. So if you go to the website of Connecting to Care and you go to the supportive services, it'll drop down. It'll bring you to the AIMS tool and you hit Connect, Get Started. It'll get you started and it'll walk you through that pathway. I want to be able to just show, we're nearing the end. Tell me you can see this video. Can you see the video? Yes? No?
No.
Give me 1 second. I think I have to share my whole screen. All right, you can see that now, right? You know what? I didn't share with sound. They should just allow it to share its sound automatically when it does it. There it goes. Okay.
Trying to do a lot of research supported interventions, helping match the specific intervention or the identified need.
Let me just get to the beginning.
Connecticut is recognized nationally as being a place that has a lot of research supported interventions, helping match the specific intervention or the identified need is what we're really working to improve.
I remember a time when I was looking for services and trying to understand how to navigate what we were dealing with at home. I was always really trying to do the hard research on my own. AIM is the Assisted Intervention Matching Tool.
The Assisted Intervention Matching Tool, referred to as the AIM tool, guides providers, parents, and caregivers through a series of questions to match services to the specific behavioral health need of a youth, or to provide parent-focused services to promote child well-being. The AIM tool can be found at connectingtocarect.org.
When AIM was introduced to me, I was just so excited, because it allowed me to put in the information regarding the needs of my family, and then I can receive a list of resources that are very specific to our situation.
We developed the tool with a lot of input from the people who'd be using the tool. So we asked families, is this the way you would think about it? It's not intended to be a diagnostic tool. The goal is to connect the family to a program that's in the ballpark of what their needs are, but then the formal assessment would happen once they set up an intake to make sure that's the right service for their child's need, or direct them in another place.
Because the AIM tool brings the resources together in one place, it simplifies my process for being able to look for providers.
I have been so proud to be part of a system in Connecticut that has so many effective treatments for different needs. To be able to provide guidance and a tool that's easily accessible makes our system even better.
I am thankful for the AIM tool. It does give me hope in being able to find resources to manage my children's mental health needs.
So that is our presentation today. If you're needing a training for AIM tool, please feel free to connect. You can scan here, it'll bring you directly to the site where you can connect with Elizabeth Kanata or myself, and we can do a full training on the AIM tool and talk about all of our services and how to get best matched. These are our contact information, both myself and Carrie, and then I have another behavioral health manager that manages all of our adolescent substance use services, and that's Amy Rodriguez. Questions?
I know Christina had put, oh, yes, Christina.
So I just wanted, I know it's available on the website that was mentioned, but I wonder if it is not currently on the 211 website, if it could be connected there as well, because so many families go to 211 for all types of human services related questions. And it seems that, you know, finding a particular website is more challenging. And so just wondering if that's something that can be considered.
Absolutely. Stephanie, right? We can kind of make
I was literally trying to look on my phone if it was already on there because I
Yeah.
think we actually link the Connecting to Care website and then go from there. But I think we can look into that and see about what we can do. But I was trying to look on my phone to confirm and I
Yeah.
wasn't able to. Sorry.
We want to make sure that anybody goes to any site, and I would say the same thing like 211, we RCT, Caroline, wherever somebody lands, we want them to be able to have access. So thank you, Christina. Any other questions? Lena?
Yes, hi everybody. Thank you so much. I just have a question. I know that they were talking about that the youth and adolescents, they can be self-refer. Then my question is that if these children, they need a parent consent, or how that work with it?
For the peer support. So Carrie, you want to talk about, because the treatment services, caregivers, adults need to be, the parents need to be involved. But the peer support, Carrie, you want to touch upon that?
Yeah. So as Chris mentioned, some of the treatment models require family participation in order for the model to be implemented. But in terms of, substance use care more broadly, and then access to the peer support services that I mentioned, caregiver consent is not required because under statute, young people have the right and that the autonomy to seek out those support services independently without guardian consent. But the gold standard is always going to be to try to involve them to the degree that that young person is interested in them being a participant in their recovery journey. But not a barrier to access. So
referral, so the youth would refer themselves. Ideally, at some point, we would want to try to engage the parent, and so the peer support would engage the parent. Same thing with treatment services. There is a window after, I believe it's 5 days. The provider needs to engage the parent for legal care. Melissa?
Thank you. I just have a quick question on the peer-to-peer program. And how are those peers matched together? And then once they are matched together, is there a check-in process to make sure that that was in fact a good fit for them?
Yeah, great question. So both organizations have been really thoughtful about their hiring of peer support staff, again, based off of their lived experience and, history perhaps of working with young people. Kind of as a philosophy of working with young people near peer age is kind of a more opportune way of engaging with young people. So we have a number of individuals who are young adults themselves who are going to be serving in this role. That is not a requirement for hire. So we do have some older adults as well who will do phenomenal work in this space. And so through that hiring process, they have both been working very diligently to the best of their ability, hire individuals who are going to look like and represent the young people that they'll be serving. So, having gender diversity on their staff, racial diversity on their staff. Both programs are expected to hire at least one bilingual Spanish-speaking staff as well. And so based off of, the young person's preferences in terms of who they might be assigned to for a peer support specialist, that information is going to be gathered by the program manager at the time of the initial outreach, and they'll do their best to accommodate those preferences in their matching of the peer. Those same program managers are going to be meeting with their staff regularly in order to help assess, the appropriateness of fit and the level of engagement of the young person. But also as part of our outcomes measure, there is a section in the outcomes tool that speaks to the young person's satisfaction with the peer support that they are receiving, whether they feel heard by their peer support specialist, whether their kind of cultural background is being respected. And so there's kind of that evaluative process through the outcomes tool as well. So lots of ways in which we're considering how those matches are aligning.
Thanks so much.
You're welcome. Any other questions? Well, I appreciate you guys taking the time today and allowing for us to present. So thank you very much.
Thank you, Chris and Carrie. So I'll now give the floor to Dr. Bozak and Andrea.
Thank you so much. And I'm going to share the presentation. Please let me know if you're able to see it.
Yes.
Great. Thank you so much for the opportunity to present today. For those who don't know me, I'm Stephanie Bozak with the Department of Children and Families, and I am here also as a tri-chair of the Connecticut Suicide Advisory Board. And I'm going to pass it to Andrea, who will introduce herself and kick us off.
Hi, everyone. I'm Andrea Duart. I'm with the Connecticut Department of Mental Health and Addiction Services. I'm in the Commissioner's Office in the Prevention Health Promotion Division, and I oversee the suicide prevention initiatives for the agency and work collaboratively with Stephanie as the Tri-Chair for the Suicide Advisory Board. And we're happy to speak with you today and provide an update to you on our efforts. If you could advance, please. So some of you, I think, have heard some of this information before, recognize some of your faces, but for anyone who's new, we just want to level set. So the State Suicide Advisory Board is under the mandate for the Department of Children and Families, but the legislation was updated in 2022 to expand to the lifespan. The board itself was actually established in 1989. It's one of the oldest pieces of legislation for this type of board in the nation. And for quite some time, a little over 10 years, we had actually been functioning as a lifespan board when we had combined efforts with the Interagency Suicide Prevention Network back in 2012. So we've been functioning that way. We're happy to have the legislative support, and that guides the work that we do, including some of the things that we're going to be talking to you about today. So Stephanie and I represent our agencies appointed by the commissioners. And then we have a third tri-chair who is a representative of a local organization with expertise in mental health and/or suicide prevention. It could be a foundation person, it could be a community organization. Generally, this is someone also with lived expertise, who may have survived an attempt, who may live with thoughts of suicide, who may be a survivor of suicide. And recently, some of you would have known our tri-chair is Ann Daigle from the Brian Daigle Foundation, but she's recently left that role after years of dedicated service. So we thank Ann. If you could advance. The mission for the Suicide Advisory Board is that we represent a diverse group of advocates and educators and leaders concerned with addressing the problem of suicide with a focus on prevention, intervention, and response. And our vision is to eliminate suicide by instilling hope across the lifespan through the use of culturally competent advocacy policy, education, collaboration, and networking, which is something that we work very hard on in the coalition work, as you can imagine. And just to give you a little bit of history, so there's quite a bit, and we have many more slides that we could have used, but this is our select. So we had released our state campaign, which actually has won national awards. In fact, it was created by students at Central Connecticut State University's communications program back in 2011 and 12, and then we released it in 2012 and continue to find that people really resonate with this messaging, so we continue to use it. Also at the national level, multiple federal agencies have adopted the same messaging, the Be the One. The VA, actually, because we had some Connecticut representatives on that planning committee. So we've influenced a number of messages, action-oriented prevention messages. So that's exciting. Our state plan process started shortly after the board came together in 2012. And the first official release of the joint plan, the lifespan plan, was in 2015 for the 2020 goal. And then we also had another state plan that was released for 2025. And we're working on our current plan. We'll talk about that in a moment. Also, a really important addition for our infrastructure is that in 2018, we established 5 regional suicide advisory boards. In Connecticut, DCF, DMIS, and DPH recognize the 5 service regions of DMIS as the suicide prevention service regions. For everyone's awareness, the 3 state agencies came to an agreement about that. And so we we operate that way under the State Suicide Advisory Board. We cooperate with funding the regional suicide advisory boards in this manner, and the data that is provided by DPH is also available to us in this regional breakdown. If you can advance. And so every 5 years, we do go through a prioritization process with the prevention, intervention, response goals, objectives, and activities. Sometimes this aligns with national level strategic planning, where there's a national strategy that's been updated. There was one that was released in 2012 and another in 2024. And then we have an opportunity to meet with our own coalition to do a prioritization process to identify which goals and objectives we would like to prioritize. If you could advance. So, as I mentioned, the National Strategy for Suicide Prevention was updated, and we have multiple committees that I'll mention in a moment that are steeped in activities. And so some of the goals and objectives that we selected to continue with and that align with the national strategy are those that we're very, have aligned activities associated with those. And we really are working on outcomes associated with the work that's happening in these committees and the work groups associated with those committees. So the goals here, goal 3, 4, and 5, are pretty much the same as the prior plan, but goals 1 and 2 have been changed. Part of that was because the national strategy made some updates to their goals that we had been aligned with. And so we went through, as I mentioned, that prioritization process with our coalition to identify which other goals would best fit our mission and vision that we have for the state. We're driven very strongly by our lived experience, folks from the survivorship and also the attempt side. And so it was really important that during the prioritization process, we incorporated all of the feedback from folks who have those experiences. And so that's why especially goal 2 is representative of multiple populations impacted by suicide. And then going back to what I mentioned in the last slide around the infrastructure development and support for sustainability, we felt was really important to have that as well. So that's why we identified goal 1. Stephanie, was there anything you'd like to add actually to this slide?
No, I think you covered it. There's a lot of information, and like Andrea said, there's probably way more that we could present, but if anyone does have questions, we tried to include a lot of information, and there's some resources and links at the end of the presentation as well. So
thanks, Stephanie. And so if you could advance to the committees. So what we work to do is to have the committees identify which goals and objectives in the state plan are associated with their work. They identify either ongoing projects or new projects that align with these goals and objectives. We are like literally moments away from releasing our new state plan. We've had a little bit of a delay because we decided to go through a reconfiguration of how we're presenting the plan. We're really excited to share this with you when the time comes. But we think it'll be a much more user-friendly experience versus like an academic process, but we'll have also academic information if people are interested in that. But that said, we do have these 7 committees that are very active in the work. Some are also linked to national efforts like the Governor's Challenge to Prevent Suicide Among Service Members and Veterans, which is what the Armed Forces Committee priority is. As I mentioned, we have the Attempt Survivor Lived Experience, strong advocacy focus. This is not a supportive group. This is an advocacy group. They've done statewide education and actually have brought it to the national level and presented at multiple conferences related to the Why We Didn't Tell You program, if some of you have seen that here in state, but have, in fact, I think they're also presenting, so they've gone international. They're going in Canada too, I've heard recently. We also have the Data to Action Committee, very important as we are a public health data-driven group to help identify where the needs and gaps exist. and then address those very strategically, identify the populations in need, and then prioritize our work around that. And then our education and advocacy is about ensuring that people are aware of not just the work that the advisory board and the coalitions and regional suicide advisory boards are doing to advance prevention, intervention, and response for suicide, but also advocating just the data, making sure that people understand and how to speak about it. It's less or so about actual policy, just to clarify that, given especially that we are co-led by state agencies. And then we have our intervention and post-vention response group, which is focused on survivor support and timely response to survivors in need, especially when we are notified of losses among those who are 24 years and under. We do have a process in collaboration, multiple state agencies, including medical examiner's office and child advocate as well, are notified, and then very pointedly, depending on where the loss has taken place, only those who need to know will be provided information to help respond more directly to the survivors impacted by the loss, whether it be a community, a school, a campus, workplace, et cetera. And then we have our lethal means committee. If you've been on a train, a bus, I'm sure you've seen a lot of the signs, some parking garages, especially about the National Suicide Prevention Lifeline. We started a signage project in 2018, and that has continued through COVID. It got a little slow, but we picked it up back up. Significant partnership with the Department of Transportation, and continuing on with Department of DEEP, oh my gosh, I'm blanking on DEEP. So anyway, DEEP with environmental, to get signage up in these high risk locations like bridges, overpasses, railways, and then where there are behaviors observed, which happen to be sometimes in parks, parking lots, things like that. And then lastly, the Zero Suicide Learning Community for Health and Behavioral Healthcare, advancing the model approach that is accepted internationally to address basically injury prevention opportunities in healthcare systems. If you could advance, Stephanie, I think this is you next.
It is, and I couldn't find my unmute. Sorry about that. So as Andrea mentioned, we have our regional suicide advisory boards that sort of feed up into the larger state suicide advisory board and coalition. And so we wanted to talk a little bit about some of the work that is being done locally with our regional suicide advisory boards. These are jointly funded by DCF and DEMAS to support the vision and the mission that we spoke about, really through coalition building, training, technical assistance, and really working with the local communities and engaging stakeholders to identify what the needs are that are unique to their location, making connections, offering trainings, doing a lot of response and intervention services as well. And some of what they provide in terms of, you can see here, there's a lot of flyers and different materials that they share out with. They provide consultation on prevention, what are the best practices around safe messaging, things like that. They've also done a lot of training. Many of you have probably heard of like QPR. That's a big one that's pretty readily available throughout the state, but they also do a lot of additional trainings. They also provide post-vention responses, like Andrea mentioned. So they're part of that post-vention team to really offer support to both communities that may be affected, offer resources if there are people who are grieving from losses, and just making sure that connections are made so that when people need to know about resources, they're available. They're also there to offer information about best practices around how to handle anniversaries. When the date comes up a year later, 2 years later, how do we want to honor those who we've lost, but do so in a safe way to really ensure that we're messaging hope and providing resources for those who may need it. They also like I mentioned, do a lot of resource exchange and print material. They also offer some peer support. So part of the state suicide advisory board, we also function as the advisory board for several grant initiatives. And this is a partnership through the Department of Mental Health and Addiction Services, the Department of Children and Families, as well as the Department of Public Health. So 3 of the grants that we have that really work towards suicide prevention here in the state include the Garrett Lee Smith State Youth Suicide Prevention Grant. And Andrea will go into a little bit more detail about these in a moment. And that is a DEMIS grant that is funded through SAMHSA that DPH and DCF sit as co-project directors. There is the Comprehensive Suicide Prevention Grant, which is a Department of Public Health grant that's funded through the Center for Disease Control and Prevention. And that, again, is jointly sort of done through DEMIS, DPH, and DCF. And then there's the 988 Capacity Improvement Grant. Again, this is a DEMIS grant funded by the Substance Abuse and Mental Health Services Administration. And I'll pass it over to get a little more detail.
Thanks, Stephanie. I think one thing that's very unique about Connecticut, and I've encountered this over and over, regardless of which population for suicide prevention that I attend meetings for in other states or national meetings, and that is that we are working extremely closely, these 3 state agencies, as sister state agencies working towards a common goal for suicide prevention across the lifespan. It is not uncommon when we talk to other states for them not even to know their counterparts in the other state agencies or to have significant difficulties in collaborating. So I feel very appreciative and with to have the partners that we do. For example, next week, myself, Stephanie, and our colleague Susan Logan, who's the project director on this grant, as well as we co-project direct the DPH grant. We're traveling to the American Association of Suicidology conference to continue our education, bringing some staff, some evaluators, some of the regional suicide advisory board representatives. So we're really pleased, to be able to go as a team and continue our education for the state's benefit. So with the Garrett Lee Smith grant, what I'll say is that we have 2 priority goals. One is a statewide goal and more of an infrastructure level impact goal, and the other is based at the local and regional level. The infrastructure is focused on advancing training opportunities for clinicians so that we can increase the identification of youth who may need to be screened for suicide, connect them to care, and ensure that they're making connections for those services. We are creating a dashboard that will be public facing, that will include suicide specific data, behavior, as well as loss data. That's in partnership, of course, with the DPH to create this dashboard. And there will be a user guide for folks so people can understand how to best use that. We've also created the starting point of what we plan to expand to as a toolkit for educating youth on the use of 988. We are using our wonderful Gizmos, Possum Guide to Mental Health, Gizmo mascot as in a cartoon version of him to help educate kids around the use of 988. One of the primary reasons for that, I think it's important to know, is because we do have legislation in Connecticut that promotes the printing of 988 resource on the back of student IDs for any youth who is 6th grade and above. And without that information, then of course the kids are not getting the guidance on what that's actually for and how to use it appropriately, and the difference between maybe calling 911 or 988. And we are one of about 25 states actually that have this type of legislation. So that resource is not only helpful so far to Connecticut, but also other states. And then the state plan also falls under this particular grant because we needed funding to support our plan development. And then at the local level, we're working with, in each of the regions, we have a priority area. And in 4 of the 5 regions, we are working with K through 12 school systems to do very comprehensive systemic continuity updates, essentially, for crisis services related to kids that need services for suicide prevention. And so it's a combination of getting all of the staff up to speed with training, making sure that their policies, procedures, and protocols are uniform across the entire system, engaging with the partners in the community, such as mobile crisis and the UCCs, ensuring that they have universal education in certain age groups for elementary, middle, and high school. And then ensuring that any youth that are identified through screening, when they are identified as having a mental health issue and then are screened using the Columbia Suicide Severity Rating Scale, are connected to care, and that there's intentional follow-up to ensure that those connections were made. We are collecting data on all of these different activities, and at some point in the future would be happy, I'm sure, to come back and share outcomes related to the 4 school systems. We did have a 5th school system in another region, but unfortunately, due to their own challenges with their town budget, they needed to pull out. We also have a partnering community component that matches up with the school system component. So we have a multi-tiered suicide prevention framework that we're using with each of these school systems. And then we have a community-led suicide prevention framework that we're using with the communities, and they overlap and intersect. So that is essentially the overview of the Garrett Lee Smith. And moving on to the next, we have the Comprehensive Suicide Prevention. Oh, I should mention that's a 5-year grant. I apologize. We started that in 2023, and it goes through 25. The Comprehensive Suicide Prevention Grant started in 2000 and was scheduled to end actually in 25, but it's been extended actually twice. So we're in a supplemental year right now, and there's actually going to be another one through the next federal fiscal year. But ideally, what we did as a state was identify priority populations, and working with 5 local health departments or districts, they are addressing the priorities of focused on these populations in their regions. And what's unique about that is historically, local health has not really played a part, at least intentionally, in suicide prevention. This is the first time in our state where health departments were intentionally prioritized to perform suicide prevention efforts. So it's been really interesting to see how this looks through their lens. And since then, there have been actually additional health departments that have utilized their block grant dollars that they can apply for under public health block grant to also participate in suicide prevention efforts, which is great. So they've influenced some of that effort as well. So we are part of this grant. That's also important to understand is the promotion of the state campaign and also 988. There have been significant efforts to support the 988 promotion in the state. Additionally, they've added DPHA measure in the behavioral risk factor surveillance survey. That's a mouthful, BRFSS, to track the one word awareness, the campaign for the state, as well as the awareness of 988. So they've been tracking the one word campaign for quite some time, but the 988 awareness was actually just for the first time put in as a measure last year. Can you advance, Stephanie? And then lastly, and Stephanie has some data to share with you all related to the youth. This is our 988 Capacity Improvement Grant. We've had a few grants. We are waiting for a new notice of funding opportunity to apply for our next grant. This particular federal grant ends at the end of September. And I did just hear this afternoon that the NOFO was announced for a 3rd time with a new date. So hopefully by the end of the month, we'll be seeing it come out from SAMHSA. But essentially, this is what these grants have really helped the state develop the 988 Contact Center, which is centralized for our state at the United Way of Connecticut. Some states have multiple contact centers. Given the size of our state, it made sense for us to create just one, where they do now answer since November all text, chat, and calls for the for any Connecticut originating 988 contacts. And what's great about that is that when someone is local, they can respond with local resources. And generally speaking, the way the system is functioning right now, the primary phone services for for AT&T, Verizon, and T-Mobile do have what's called geo-directed contact. And so if someone happens to be in Connecticut, they will get directed to the center in Connecticut for those local resources versus if they were out of state, they might be connected to a different location. So what's important to understand is the importance of that. We can't necessarily tell where this person is calling from. It's not geolocation. That's a different kind of thing. That's like pinging someone if they're in an emergency and they're contacting 911 and they can tell maybe where that person is and get to that person. That's not how the contact center functions. But it is important that they're directed to the contact center where they are actually located if they do need those services and need an immediate response of some type, whether it be mobile crisis or whether it be a 911 active rescue of some sort. So the crisis service system connected to 988 has been expanding, and that's a whole nother story, but let's stay focused on the use of 988 services in Connecticut. And Stephanie, do you want to take over for the next
Yeah,
slide?
I'll take over and go over them as quickly as possible because I know that we are running out of time. So you've heard this all before. We have really developed our system here in Connecticut to match SAMHSA's best practices. So I think United Way already touched upon this, someone to talk to, someone to respond, and somewhere safe to go. And so 988 is part of that crucially. And some of the data that we have related to 988, you can see that a lot of the calls are actually older than the youth. So for youth, we have 447 that are between the ages of 13 and 17, and 111 that are between the ages of 0 to 12. I'm assuming that they're older than 0. There are a number of callers that we don't necessarily get the demographics of. And so there are a number of callers that we don't have the information about, but we do try our best to get that information whenever possible. And I apologize, this information is from January through May of this year. We have found, however, that youth are using the chat and text a little bit more on the 988 option. So you can see that we have about 700 that have used the text and chat over the January to April 30th, and this is for under 18, and that is from a total of 3,353 contacts through the chat and text on 988. We also wanted to leave you with some data. This is from the Connecticut Youth Risk Behavior Survey. This is done, I believe, every 2 years. Andrea, correct me if I'm wrong. 2 years?
That's correct. Yep.
Thank you.
On odd years. Yep.
On odd years. So they actually just finished it last year and released some information. So this was the data that we found. And you can see that over the last year, we have actually decreased from 15.7 to about 12% of high school students who were asked that said that they were considering suicide. Some caveats to that: they don't poll every school. They take a sampling of schools. And of course, we are limited to those who are willing to answer the question. So it's a best approximation of the information. And this is something that we've tracked over time so that you can see. Now, rates are relatively low. Again, a caveat is being cautious about when interpreting this data, but we're hopeful that this information and that we're doing a good job of really supporting schools and giving them the necessary resources so that if students are feeling lonely, depressed, anxious, that they know where to turn to. In terms of the percentage of students who have actually attempted suicide, you can see here again the rates, the percentages. And the way that the question is asked is they ask it related to the past year. So the 12 months before they actually ask the survey. So again, in 2025, you can see that the percentage dropped from 7.7 from the previous time that they did the survey to 5.7 in 2025. The last thing we wanted to leave you with is some resources. So we talked about some of the trainings. This is directly from our Prevent Suicide CT website, and you can scan that QR code and access a whole bunch of different trainings. Some are listed here. They're grouped into the general public or community versus clinicians or professionals in the field. And then there's also some additional resources. In addition, the website has a whole host of other resources. So there are materials that you can see here. The signage, which was funded from DPH that Andrea kind of spoke about earlier from the grant. There's mental health shareables if you want to use any of those shareables on your social media or anything like that, including graphics and brochures, and a material in order form if you want hard copy or print material for yourself. And that is it.
So I know we have a question in the chat and then Howard, and then unfortunately we'll probably have to close out the meeting, but if anyone has any additional questions, feel free to email to me and I can send them over to Stephanie and Andrea.
And I'm so sorry, I cannot see the chat. So
Sure. I did see the question in the chat. I think it's about the state plan and how we track outcomes, essentially. I think what's important to understand is that the state plan is for everyone. And so there are the goals and objectives that we will identify for that align with federal grants. And we do track those through a significant evaluation process, IRB approvals, all of that. So anything that we as state agencies oversee related to these grants, we have outcome data for that. But we do have many coalition partners that also are doing activities that are keeping track of their own outcomes. So because the state plan is for everyone, we are not tracking every single goal and objective in there and opportunity, but we are hoping that people will identify opportunities for themselves in the work that they're doing and will help us to collect outcomes as well. Stephanie, is there anything you'd like to add to that?
Yeah, no, I think that was great. And I think the one thing I would add is that the state plan is really sort of a document to guide all of our efforts to really shepherd us to the same horizon, right? And so anyone who's doing this work, these are the overarching goals that we're really sort of looking at. So like Andrea said, there are certainly activities that we do and are able to track, but we really have this state plan as something for anyone to be able to say, you know what, this is a passion of mine. This is something that I want to help with. And they're able to pick that up and get ideas for how they can contribute and work towards suicide prevention as well.
Thank you.
Howard?
Yeah, hi. I just want to connect the dots and maybe close the circle of today's meeting. I want to make the connection between the UCCs and the work that you're doing. First of all, great presentation and a great conference that you guys sponsored last week. So kudos to you. But I also want to just share some of the observations that I've had over the years, both at Connecticut Children's and through the work we're doing through the Advocate's Office, of families and young people who've expressed real, fear about going to emergency rooms. And that fear oftentimes inhibited their ability and willingness to disclose to their family members, to therapists, and to others their struggles that they were having. And for me, it just illustrates the real opportunity that we can work more closely together to promote the UCCs as an alternative, a safe alternative that will perhaps enable people to be a little bit more open in seeking out care, in addition to just picking up the phone and calling 988. So I just wanted to congratulate you and look for that opportunity for us to work more closely together.
Yeah, and it's such a great point, Howard, and I really appreciate that. I'm hearing exactly our keynote speaker from the conference, right? How do we support without aiming to fix? Because sometimes that fixing ends up being felt very differently by those who are experiencing those thoughts of suicide. So absolutely great point. And how do we help support them with the level of care that they need in that moment? And UCCs are part of that.
Thank you, and thank you, everyone. So our next meeting will be June 10th. It's currently scheduled for June 3rd. You will see that change from me right after this meeting ends. And I will pass it to Claudio for any closing remarks.
Thank you, Emily. Just want to appreciate everyone's time today. Fantastic presentations. And again, celebrating May as Mental Health Month, and really excited to celebrate the legislative work that we accomplished, both the TCB bill and lots of other good things that I think support overall wellness for our families and children. So thank you, and be well. We'll see you in June.